Hello, this is session 6 of clinical decision making. Today we're going to talk about evidence-based medicine. This is a really big topic, and so we're just going to cover the overview, but it's also a topic that's very, very important in your medical training. Um, just to how to look up any information you don't know, how to stay up to date, um, and just how to continually grow as a doctor even after you are done with medical school. Um, okay, so objectives, we're going to talk about the principles and importance of evidence-based medicine. We're going to talk about 5 main steps that include we formulate the question, what are we searching for, and then we search the literature. We appraise the article, meaning we evaluate the article, um, and then we apply that information to our patient, and then we evaluate the outcome and say, did that help? Did that not help? So we'll actually go over those in a couple of practical cases, of course. Okay, so as always, there's a lot of definitions for um, evidence-based medicine. Um, and as always, I don't necessarily want you to memorize the definition. I want you to understand the idea. So I want you to be able to define evidence-based medicine in your own words um, rather than the words that I'm giving you specifically. Um, so here it's defined as the use of current best evidence in making decisions about the care of individuals. So it's based on research evidence, clinical experience, and consistent with the patient values. And so those are all very important. So we want to be uh, looking at the evidence, looking at the research, but then we want to combine that with our clinical experience and our clinical judgment as a doctor. And then we want to also consider the patient's values and what they're wanting, because maybe something that is good for one patient is not good for another patient, just like we talked about in the last lecture of shared decision making. Okay, so in some ways, evidence-based medicine has been around for a long time, but in its current form, it hasn't actually been around for very long. And so it was really started in the 1990s by clinical epidemiologists. Um, and if you looked in 1992, there wasn't very many articles on evidence-based medicine. And in fact, there's one article in JAMA, the Journal of the American Medical Association, in 1992 that is entitled "Evidence-Based Medicine: A New Approach." So it was seen as new at that time, or the way that we think of evidence-based medicine was new at that time. In 1993 to the year 2000, in JAMA, there was a series of articles that came out that were talking about a user's guide to the medical literature, like kind of teaching doctors at the time how to look up research and how to review the medical literature to uh, to help them in their clinical practice. In general, in the 1990s, there was 3 main trends. There was something that came out called systematic reviews, which we'll talk more about. These are overarching things, a lot of times like a document that is written by the Ministry of Health or the government or like the American Medical Association to try to help doctors, give them guidelines. There was search engines that were developed. So just as we developed the internet, this is what really was making us able to combine all of the information from around the world. But then there was starting to be so much information on the internet that it was becoming hard to find. So just different search engines, um, uh, like Google is a search engine, obviously, but more so like a medical search engine, a search engine that would be uh, uh, specifically looking for through the medical literature to help you find something. Um, and then knowledge distillation. Uh, this means kind of like taking all the knowledge that's out there and bringing it into a form, or just making it more simple, or reducing the amount of information into something that is more understandable. And then when we look at the year 2000, there's more than 1,000 articles uh, online, and now, of course, there's just thousands of thousands. So here's a couple uh, definitions here. So um, they're looking at what is clinical epidemiology, and so they're saying that is the application of epidemiologic principles and problems encountered in clinical medicine. And so this other Sackett et al. In a different article was saying it's the basic science for clinical medicine. And and so we're looking at statistics, we're looking at research. Kind of the way that I think about it is that clinical epidemiology is the all the research and all the evidence that helps us make our evidence-based decisions in our clinical practice. So in general, with the idea of evidence-based medicine, no one really disagrees with it. Um, Everyone is for it. In practice, it becomes a little bit more difficult. But all major medical journals have adopted this idea. In fact, it's hard to submit an article or get published if you haven't actually done research. No one cares about just your opinion on something. Like they want to know, what have you researched? What real evidence do you have? And there's centers for evidence-based medicine all over the world. Um, so when we look at the pros and cons, the good things and the bad things about evidence-based medicine, um, it's really a new paradigm in medicine. Like it's a whole new way of practicing medicine, because it used to be about your experience, or your personal experience, or the experience of people you're talking to. Um, um, but now the literature is constantly being updated, and we need to continue to apply that new information in our practices. And it's really, especially with the starting of the internet, it's probably, one of the things that has uh, changed medicine almost more than any other thing in history. Of course, the Human Genome Project, where we identified all the different genes in the body, was a huge thing as well. Some people say, it's not really new. We've always done this, so it's not really as uh, different as some people are saying. Um, and really, like maybe a middle ground um, that we can say about it. It is really good, but we need to be careful when we're searching the evidence, because if we don't know how to uh, decide whether an article or a research study is valid, or whether it applies to our patient, we might use it, and we're relying so much on that, we're not thinking about it logically. We're just taking the evidence and applying it to our patient, and possibly it doesn't go along with that patient's values. Possibly that study was done on children, so it doesn't apply to adults. I think most people would say this is a very good thing, but we need to know how to do evidence-based medicine. It's not something that um, can be done without some training. So uh, here's some different reasons why evidence-based medicine is important. One is just there doing when we're looking at all the medical literature, all the textbooks and all the research. There's so much information out there. Um, and so we need to know, how do we get to the most important medicine, or get to the most important information, sorry. Um, and we need to know how to keep current with the literature. When there's textbooks, um, sometimes it might take years for new information to get into textbooks, but evidence-based medicine online, we're able to keep up with the current literature at a much faster pace. One thing is, we talked about before in one of our sessions, is that sometimes there's a tendency for the clinical performance of doctors to deteriorate over time. And so we call it the slippery slope. And so maybe a doctor is learned all the most up-to-date information when he was in medical school. And for the first year or two, that information is great. But if there's new information and that doctor is not keeping up to date with the medical literature, his performance is going to go down over time. We talked about the idea before about 25 years of experience versus another doctor that has 1 year of experience, and he's repeated that 25 times. And so where he just keeps making the same mistakes over and over every year, but now he feels more and more confident about the mistakes he's making over time. Maybe you've seen some doctors like this already in your training. For sure, you will see doctors like that as you get into the hospital more, and as you just understand what's a good decision and what's a bad decision. You'll kind of see doctors that are staying up to date, and you'll see other doctors that are just making these very old decisions that are no longer correct. One thing that evidence-based medicine is important too is that, at least in America, and I believe in England too, we have this idea of continuous medical education. And that's where doctors need to go to conferences or take exams every year or every 5 years to continue to keep their license active. But when they've done studies on these, a lot of times they've shown that really, like the traditional continuous medical education, where doctors just go to conferences every couple years, it doesn't really improve their clinical performance. But evidence-based medicine encourages a doctor to continue to learn, and continue to learn about information that they really care about that's applicable to them. Like, like if there's a patient that comes in and you don't know how to treat that disease, and you go look up the information about it, the evidence-based medicine about this person's case, you're going to put that into practice with that patient, and hopefully you're going to remember that information more than if you just went to a conference about diabetes. I, Hopefully you're going to remember that information a lot more. So here are a few facts about evidence-based medicine. There is a lot of information. More than 25,000 different journals. At least 6 million articles are published every year. There's 17,000 biomedical books produced every year. We have thousands of diseases. We have new therapeutic regimens, new medicines, new ways of treating patients that come out every year. But a lot of times when we look at textbooks, a lot of times they're out of date, because a new treatment might not be included, or an old treatment might not be removed for sometimes up to 10 years. And so that is just way too slow for how we practice medicine now. So we've already discussed this, but a lot of times doctors, they know a lot of information, especially during residency or right after residency, but it's really hard to keep up to date with the information. And a lot of doctors just decide that it's not important to them. Um, but a lot of times this information, this knowledge, uh, will deteriorate pretty rapidly over time. This is just a graph to show what we're. So if we have, you know, 80% of the knowledge at the end of residency, it's just going to keep going down and down and down. And the mistakes that the amount of information that we don't know is going to continue to rise and rise and rise over time. So there's a lot of reasons why evidence-based medicine is important, but one is that it's so that we can clearly explain the reasons why we're making our decisions to patients and their families. Another thing is that we can prove to our other colleagues, to other doctors, to managers or administrators why something is effective and important and also cost effective. Like if a manager is trying to make the decision, is this treatment beneficial and is this treatment cost effective? With evidence-based medicine, we can prove that, but if we don't have any evidence for what we're doing, um, a manager might make a wrong decision on what is the best equipment to have, or like, do we really need this new CT scan? If with evidence we can say, um, uh, yeah, we are actually diagnosing a lot more cancer with this and able to treat the cancer earlier, and so it's actually saving us money. Um, the manager would be a lot more likely to buy this new CT scan machine than if we don't know anything about it. Another thing is it just leads us to be actually providing the best care for patients, and it allows us to standardize the care. So, which is important. Like we want patients to be getting good care and a certain quality of care at every hospital and at every clinic, rather than just the clinics that have the most money. Like we want to have a certain standard that we are expecting doctors to provide and hospitals are expected to provide. So this is the main uh, topic of the lecture right here. We want to talk about the different steps for practicing evidence-based medicine. First thing, we want to take the question or convert the need for information into an answerable question. Like if a 50-year-old patient comes in with diabetes and we want to know what medicine to give, then the question might be, what is the best first line medication? What is the best first medication to give to a patient with newly diagnosed diabetes? So we've taken the information that we have about the patient and changed it into a question that can be answered. And so then we're going to find the best evidence with which to answer the question. We'll talk about where we can find the best evidence. We're going to appraise the evidence, meaning examine the evidence and decide what uh, is this research good research? Does it apply to our patient? And then we're going to integrate that evidence with our clinical expertise. We're going to say, okay, now I learned that metformin is the best thing to give um, to a patient with newly diagnosed diabetes. We're going to take that and say, okay, this patient, I've diagnosed him with diabetes. He does need a medication. Um, I, and then we're going to put that together and apply that evidence to the patient. We're going to give him metformin. And then we're going to evaluate our effectiveness. And so we're going to see how we're going to see that patient again. We're going to say, did it help or not? And then if it helped, we think, okay, like I think we did these steps well, and we can, or if it didn't help, we can think about, why did it not help? Is there any type of way that I could have researched evidence differently? Is there a different question that I should have come up with that might help us the next time that we're looking for evidence? So first thing is we're formulating the question. Um, we want it to be a clear question, like wadah, and concise, like gasir, like is as short as possible. And we want it to have a problem, an intervention, and an outcome. Um, and so, like for example, what is the evidence for the effectiveness of X um, uh, in a client with a problem? So, for example, what is the evidence for the effectiveness of metformin to um, uh, correct the high blood sugar, that'd be the Y, in a client with diabetes? Or we could say, for the same thing, what is the evidence for the effectiveness of metformin to decrease mortality or decrease the death rate of patients with diabetes? It just kind of depends on what is the information that you're looking for. And a lot of times we'll talk about, you'll for sure see this at other times in your career, the PICO format, PICO. So first we want to make sure that every question that we have has these four different things. And so we want to talk about the population or the problem you're studying. For example, patients with diabetes, or diabetes as a disease in general. And we want to have something about the intervention you are studying, whether that is the medicine that you're giving or the surgery that you are doing, the antibiotic you are giving, something along those lines. I, ideally, the question should also have a comparison or alternative intervention. And that could even be doing nothing. Like, what is the evidence for giving metformin to decrease mortality, decrease the death rate in a patient with diabetes versus giving insulin, or versus not giving any medicine, or versus um, just telling them to change their diet, something like that. Um, last thing is outcome or reason for using the intervention. That's what we talked about here. Maybe it's increase life expectancy, decrease the death rate, decrease heart attacks, decrease strokes, or decrease cancer recurrence, something about the outcome that you're studying. So there's different types of questions that we can talk about. Um, Sometimes the type of question might be a diagnostic question. We're talking about what test should we order, or how should we interpret a test? Like, is it necessary to, if someone has symptoms of COVID, is it important for us to um, order a diagnostic test? Or if a diagnostic test comes up positive, what's the likelihood that it is a true positive test? Um, Something like that. So, or we could be a therapy question. How do we select the treatments to offer patients more good than harm? Like, would this antibiotic that we're giving the patient cause more benefit to the patient, or would it harm the patient? Are the side effects worse than the treatment or the chemotherapy or something like that? So, prognosis questions. How do we estimate the patient's clinical course over time and anticipate complications of disease? Like, what's the likelihood that a patient with stage 2 pancreatic cancer will uh, live 5 years? Or what's the likelihood if they get chemotherapy? Um, uh, will they live 5 years? Um, and then harm or etiology. Harm would be like if what's the likelihood of a patient dying from a colonoscopy or from a surgery, or what's the likelihood of a certain side effect about a patient's medication. So um, if we look at some examples of different questions, one example would be, is oral rehydration in the emergency room more cost effective than IV rehydration? So, what is I want you guys to tell me, what is the patient or population that's being studied? What is the intervention that's being studied? Like, what is the treatment? Is it being compared to anything else? um, and what is the outcome that they're looking for. So first of all, what's the population being studied? Sorry, we're getting there. In this one, it was not identified. They just kind of said patients in general rather than saying a specific type of patient. So maybe they could have said, uh, 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 let's get back here, is oral rehydration in the emergency room more cost effective than IV rehydration in infants or in infants with vomiting, possibly? Um, uh, the intervention being given was oral rehydration. They did compare it to IV rehydration, and the outcome is it cost effective? So they could have had a different outcome. They could have said in preventing death, or in preventing, or in possibly decreasing the length of hospitalization if they're trying to rehydrate them quicker. Um, okay, let's do another example here. Will Atrovent help prevent hospitalization of my 2-year-old patient with an acute asthma exacerbation? So now that you have a little experience, what would be the patient or population that's studied in this? So it's very specific, right? Like this, it's a 2-year-old patient. What's the intervention? Atrovent. What's the comparison? Do you see anything that it's being compared to? I don't. So there's no comparison. The outcome, prevent hospitalization. So that's the outcome that they're looking for there. So did we get it right? Yeah, so it's a child with acute asthma. Um, it's a intervention Atrovent comparison. Maybe they could have compared it to, rather than giving albuterol, any salbutamol, or standard therapy, or no therapy, or antibiotics, something like that. Um, Outcome was to prevent hospitalization. Okay, one more example. Is 10 days of antibiotic therapy better than 5 days of antibiotic therapy when treating an infant um, uh, with acute otitis media? So, patient or population, what is it? It's an infant, right? An infant with acute otitis media. Intervention would be 10 days of antibiotics. Comparison, 5 days of antibiotics, right? Outcome, what do you think? It's not really identified, right? It just says better. Maybe they could have been more specific. What does better mean? Does that mean more cost effective? Does that mean help resolve the symptoms quicker? Does that mean decreasing the risk of recurrence? Like when you see a word like better or a word like patience, you know that that's a very general term and that's not being specific enough. Maybe a persistent effusion behind the ear, maybe decreasing the rate of that. Um, okay. Okay. Um, we talked about the question, which is a very important step. And now we're going to search the data. There is a lot of places that you can search for data. But one place that I think is probably going to be the most important one for you right now, especially as you'll be doing some research projects next year, um, is PubMed. Uh, so, um, so the first thing we're gonna, and we'll walk through some examples, but the first step is search each concept separately. So, uh, if the question is about giving metformin to adult patients with diabetes, newly diagnosed diabetes, you can type in um, diabetes and then do a search, and then you can do a search for metformin. But then you can also, step two, combine the sets of articles by putting uh, diabetes and metformin, or you can do diabetes um, or metformin if you want both sets of articles. But a lot of times you'll see that, like if you put in diabetes, you're going to get just thousands and thousands of articles, but you want something more specific. So you're going to be saying like putting in things like diabetes and metformin and uh, increased life expectancy, something like that. And so then you can limit the results to the publication type that you want, whether it's a, like a type of study. You can limit it to human studies only. You can limit it by the language. You can limit it to the way that the research has been designed, whether that's a randomized controlled study or a cohort study. We'll talk about some of what those mean. You can say only within the last 5 years. Um, and then you can review all the titles and the abstracts, like the just summaries of each article. And then you can just select the specific articles that you want to read and study more closely. Um, so let's talk a little bit about PubMed. That's the main example that we're going to be going through today. Has research from many different medical journals on almost all health and medicine topics. There, I mean, there's millions, 21 million at least abstracts or citations from 5,000 journals, all since 1966, and it even has a link to articles that were before that time. It covers all of these topics here. It's free, and a lot of times what it will do is it'll take you to an abstract where you can read the abstract, and some of the articles will be free, but other articles you can just read the abstract, and then you would have to actually pay to get the article. Um, like we talked about in the literature search steps a couple slides before, um, you can search for different articles by keywords, by the name of the author, by the name of the journal. You can combine the different searches together, like metformin and um, a certain author's name and a certain journal name. You can link to related articles to what you're talking about, and you can also they have links that will take you to outside sources where you can uh, purchase the full article if you want. There's a clinical queries section that's even more specific, that's really giving you specific clinical trials that would answer questions specifically about like treating the way to treat a disease in your own practice. So this is the home page. Actually, I'm going to show you. This is how the home page used to look, and then they've updated a little bit recently. If you just go to pubmed.gov, it will take you here. And then, so it's even written right here, pubmed.gov. I know in the search bar it says a little something different, but you could just put in pubmed.gov. Takes you to here. And then in the search bar right here, you can type in kind of whatever you're talking about. So here in the search bar, they put obesity. And then, so all of these articles come up. So there's 92,911 articles. And then as you you can click on one of these articles here. So I think they clicked on this one right here. Now they clicked on a different one. But and then the abstract will pop up. So here you can at least see the abstract, and then sometimes you can click on a link like here, full text, and it will be free. Other times it'll take you to a different spot where you might actually have to pay. And then as well, you can click on limits of the, like if you click on this advanced button here, it'll take you to a place here where you can click on the limits. And so you can limit your search to, actually it's on this page, so you would click on limits right here. That will take you to this page where you can limit your question to a lot of different areas. You can say, okay, I only want this articles in English. I only want it for male or female. I only want it for people that are of a certain age. I only want it in this type of journal. I only want it from these dates, human or animal trials. And then you can kind of it helps narrow your search more. So we're going to, when we go over some examples later, we're going to talk more about, I'm going to show you more, I'll get online and show you how to use PubMed, as well as a few other resources that could be helpful to you. So after we get the evidence, so we've gone to an abstract, read an article, we want to appraise that evidence or evaluate it or analyze it. So definition for critical appraisal would be systematically examining the research evidence to assess its validity, to assess its results and its relevance for us, in our case, before we actually put it into place. So the idea in general is critically appraising it is analyzing it in a systematic way to make sure it's a reliable article and that it applies to our specific case. And because really, if we're using poor evidence, whether that means a research article that is not good research, like the research was not done well, or it's an article that doesn't apply to our case, that's the same as using no evidence at all. Like maybe it's even worse, because at least if you're using no evidence at all, you're using some clinical judgment. But if you're just going to apply an article that doesn't apply or that's not based on good research, it's probably actually worse than using no evidence at all. All of these things are important. A reputation of an author, attention to details in the study, how well was the study designed. We'll talk about some of these too, like when we're appraising it in a second. Did they describe the results well? Is the impact of the study like does it have an impact, or does it not really change the way that we're doing things? So when we're appraising things, these are some of the main points. Is it valid? Meaning, can I trust this information? So was this study done well? We'll get into some other questions that I think are important to ask, but can I trust this information? Was the study done well? Was it documented? Are the results clear? Clinical importance. So if this study is true, will this make an important difference, or it doesn't really make a difference? So is it a clinically important study? Um, is it applicable? Can I use the information in this instance, meaning with this specific patient? Is it applicable to what I'm doing? So this idea of, is it valid? Is it important? And is it applicable? That's the overarching things. Here are some different questions that I'd say. I mean, in general, you need to know like these main ideas, um, which lead to a lot of these questions here. Is the focus of the research clearly stated? Did they say what they were going to do from the beginning? Can the research proposal be generalized to our group? Meaning, we're talking about applicability. Is it applicable to our patient? Um, was the sample size justified? This is getting into, is it valid? Was the sample size too small? Like if we do a research on 10 people, can we really use that evidence um, on people all around the world? Probably not. Um, can we use, if it was just done for people in one state in America, um, can we apply that to patients in Africa? Maybe not. Um, so are the measurement tools valid and justified? Like when how they studied it, was it a valid tool? Did any unwanted event occur during the study? Sometimes you'll see a study where the study was stopped um, uh, because too many people were having a side effect, or for some reason, um, uh, the it got it like they couldn't, maybe they had 20,000 patients, but they couldn't find 5,000 patients that were in the study after 5 years. So that's a lot of patients to drop out of a study and is going to make the study not valid anymore. Like that's too many patients to drop out of a study. Like we want to know, why did they drop out? Maybe there was something with the treatment that was giving them a side effect, and they just never reported it, and they just never went back to get evaluated. That would be an unwanted event. Is the data described well? A lot of these, will that is it stated well? Was it done validly? Was the data described well? Are the results of the study valid? We'll talk about how to evaluate that in another place too. But what are the results? What do the results mean? Um, so sometimes it's hard to even understand. This seems like an obvious question, but sometimes the results are written in a very, with a lot of medical terminology in a very wordy way, like in a very um, um, just a high level of medical language manner. And sometimes it's just hard to know, like, okay, what are the results really telling me? And then how do these results compare with previous reports? Does this agree with other studies done before? Does it disagree? And then lastly, the applicability. Does this actually help me care for my patients better? So when we um, look at degrees of evidence, um, there's a lot of different types of studies that are done. Um, and so as you move up this, the amount of available literature decreases, so there's less meta-analysis than there are systematic reviews, but it increases its relevance to the clinical setting. So for example, like research done on animals is going to be less relevant or less applicable to a human patient than a case report about a human patient, or which is going to be less applicable than a big randomized controlled study or a systematic review or a meta-analysis. And so the level of evidence gets better and better as we move up, but the amount of evidence that we have gets less and less. Um, so we'll talk about all these different ones here. So a meta-analysis is where you combine data, pertinent data from several different studies to develop a single conclusion that has greater statistical power. So we're pulling all of these different studies together to try to come up with like if 15 studies have been done about giving metformin to decrease uh, uh, to increase life expectancy or decrease mortality in patients newly diagnosed with diabetes, we're going to take all of those studies and put them together, and that's going to give us a stronger level of evidence so that we can make the best decision. So really, and this kind of can probably make intuitive sense, is the validity of that meta-analysis. It depends on the quality of the reviews or the studies on which it's based. And so if there's 15 studies, like I said, but those studies aren't of very high quality, then that's going to mean the meta-analysis is not a very high quality either. You know, if you are building a house on um, uh, but not using strong cement, it's going to collapse. And so the same thing, if you have all these studies that are um, uh, um, not high quality studies, you're not going to have a high quality meta-analysis. But if you have high quality studies, which is the reason why we want to only get pertinent data or good data to make up a meta-analysis, if we want a strong meta-analysis, the studies have to be strong as well. So systematic reviews. This is normally a document that's written by a panel. It could be by the Ministry of Health or the government of a country or a medical society, say like the Jordan Medical Society, might put out a document on how to treat hypertension. And so they group, that panel of doctors, that group of doctors or group of researchers look at a review of a lot of different studies, and then they publish their opinion or their review and say, okay, because of all these studies, this is what we think we should do. Whereas a meta-analysis, that's actually more of like a study that is being done. It's a study of studies, rather than a systematic review is more of this review that has been done, and then a new document is created on providing recommendations of often on what we should do. And so a high quality systematic review finds all the relevant published and unpublished studies. They assess each study, they group it all together in a way that's unbiased, and they present hopefully an impartial study or an unbiased study, an unbiased summary of the findings, and then we'll also discuss any flaws in the evidence. And so this is very hard to do. You know, when I highlighted these words all and unbiased, that is very hard to do. But that's what these organizations are seeking to do. But you'll find that sometimes one group might have a systematic review that says one thing and another systematic review that says something else on the same topic. And so obviously there's some room for bias in all of these things. So a randomized controlled study is where a group of people are, like a similar group of people, are randomly assigned to two or more groups to test a specific drug or a specific treatment. And so there's the experimental group. They receive the treatment being tested. There's the other group, the control group, that receives an alternative treatment. That might be a placebo. If you know placebo, that's like the person might take a medicine, but it doesn't have, it looks like a medicine, like they're taking a pill, but there's actually no medicine in it. And so, or possibly no treatment at all, or it could be or a completely different medicine, or it could be comparing the experimental group might receive medicine, whereas the control group receives surgery, or just comparing really any two different types of treatments. So the groups are then followed, um, um, and we kind of study them to see how effective the experimental treatment was. The outcomes are uh, measured normally at a specific time that's generally decided at the beginning of the study, and then any of difference between the groups is assessed statistically. So the main thing here is these group people, like there's 100 people, you don't pick them based on a certain characteristic. You just randomly assign them to the two groups. So maybe like these people all have colon cancer, and then we just give some people a medicine versus other people we uh, do a surgery, and then we follow up them to see how they're doing. This is in contrast to a cohort study. In a cohort study, there's normally just one group, and it's still random individuals are chosen from the group, um, and they're still evaluated at specific times for a specific disease or an outcome. And then it's kind of looked at which risk factors are most associated with that disease or outcome. So, for example, so if we have so 50 students from Hashemite University are randomly chosen at the beginning of their first year of medical school. So 25 of them are from Amman, and 25 are from Zarqa, 25 are Palestinian, and 25 are Jordanian. So at the end of their first year, they're all given a PHQ-9 depression questionnaire. If you're not familiar with that, it's just a form with 9 different questions on it. And if a patient has enough, they answer yes to enough questions, then sometimes we'll diagnose them with depression. So this is a questionnaire to evaluate people whether they have depression or not. It's found that at the end of their first year, 10 students from Zarqa meet the criteria for depression, and 2 students from Amman meet the criteria for depression. And also, 10 Palestinian students meet the criteria for depression versus 9 Jordanian students meet the criteria for depression. So, from this study, what might we conclude? We might conclude that being Palestinian or Jordanian is not a risk factor for developing clinical depression during the first year of medical school. So, because there's approximately the same, and we'll talk about more statistical analysis later, but for right now, we're just talking about just looking at the data in general. And so there's about the same number that have depression. So we think that's probably not a strong risk factor. But looking at it, we might look at living in Zarqa. That is a risk factor for depression because 10 students from Zarqa and only 2 students from Amman met the criteria for depression. The ultimate question is this study a valid, well-done study? So if we kind of look at some of our questions before. So is the focus of the research clearly stated? This is just a rough draft here, so maybe it's not all stated. One thing, though, that might jump out is, was the sample size justified? Was it too small? Yeah, if it's only 50 students, that might not be a good sample size. We might need to check with more students. Right now, we're only going with 25 students from each city, so we don't know if we can really draw a strong conclusion from that evidence or not. And in general, too, as we looked here, like a cohort study is going to have less power than a randomized control study, because rather than we're not comparing this to any other group. Maybe it would be important to have 2 groups where one group, whatever it is, does courses online versus another group that does courses on campus. Or maybe we could compare 2 different universities in Jordan and then also compare. So, are there really, um, if we compared it to University of Jordan, do we get the same results where there are significantly more students from Zarqa that go to University of Jordan that are having depression, um, or is it the same there? That would give it more evidence that living in Zarqa is a risk factor. So a case control study, um, this one is we're going to compare patients that have a disease. These are the cases with patients that don't have the disease. These are going to be called the controls. And we're going to look back retrospectively to compare how frequently the exposure to a risk factor is present in each group. And we're trying to determine the relationship between the risk factor and the disease. And so the big thing here is it's retrospectively, which generally we don't like to do because it's way more open to biases. So the randomized controlled study, as well as the cohort study, are prospective studies. And so we identify the patients that we're going to follow, and then we follow up with them at a later time. Retrospectively, we're looking back and trying to see, is there any reason why uh, uh, we're seeing the data that we're seeing now? So, for example, um, if we look at the same case but from a different angle, we have 50 students from Hashemite University that are found to have depression at the end of their first year of medical school. It's found that 40 of these students live in Zarqa and 10 of them live in Amman. Also, 26 students are Palestinian and 24 students are Jordanian. And so when we're looking at this study, we might think that, okay, there's a correlation between living in Zarqa and having depression after the first year of medical school. The problem with the case control study, like I just mentioned, is it's just open to a lot more biases. And so, like if we look at an example of smoking and obesity, if we look at smoking and obesity, maybe we might find that there is a correlation. So, like a higher percentage of obese people smoke than people that are not obese. But that doesn't necessarily mean that obesity causes smoking or that smoking causes obesity. Um, and so that's why we need to be very careful with these case control studies or any study where we're doing something retrospectively. So a case report, I remember we're going down this pyramid here on reliability of the evidence. So now we're down to here. A case report is an article that's describing and interpreting an individual case. And it's often written in the form of a story. So this is a patient comes in to your office that has maybe an unusual presentation of colon cancer. And so you write about that patient, that this 54-year-old patient came in, he had vomiting, we were looking for a lot of different things, but then we found out later that he had colon cancer. So he didn't have any bleeding, it's just a different case. So you write about this case, um, I, or that you write about a case that a person has a rash, you didn't know exactly what it was, it looked like this, you gave them prednisone or steroids and it got better, and you just write that story and publish it. So there's not a lot of evidence there, but this is how evidence a lot of times can start, or even the animal or laboratory studies, which are studies performed on animals or in a lab setting. And of course, like when you're doing a study in a lab, it's going to be different than in real life. Um, so with these things, though, a lot of times evidence will start here. We'll start testing on animals or in labs, or maybe it starts by multiple different doctors are seeing these similar cases, And as more of the doctors publish their findings and what worked or what didn't work, um, we're able to start developing that information and seeing a similarity between the case reports, and then maybe a study is done um, that studies the intervention more. So, for example, with COVID, we will be doing uh, uh, drug testing on animals or in a lab setting, or maybe sometimes like a doctor might just try a medication, like might try chloroquine, and then they will I, I say, hey, like chloroquine seemed to, like my patient recovered quickly, it seemed to help. But then when we actually go in and study it, maybe we see, okay, it actually doesn't help when we study it on a bigger group, but in this one case report, we saw that it did help. Okay, number four, implementing the evidence. And so now we're going to take that evidence, we're going to return to the patient, and we're going to apply that evidence, and we're going to combine that with our clinical expertise as well as the preferences of the patient, and we're going to apply it. I don't have a lot more to say on that, besides that we're just going to take that evidence, we're going to combine it with our clinical expertise about the patient, and we're going to take um, the patient's preferences, and we're going to apply the treatment. Lastly, we're going to evaluate the impact of the evidence. We're going to look at the patient outcome. We're going to say, did they improve or did they not improve? We're going to look at cost effectiveness. Did it cost too much? Was the cost worth it? You know, like if we gave someone chemotherapy and it cost 20,000 JD, um, is that really feasible? Or was that, if it helped save their life for an extra 20 years, maybe it's worth it. If it only prolonged their life for another 2 months, maybe it wasn't worth it. The patient satisfaction, we can look at that. Is the patient happy with the results? And also our satisfaction. Are we happy with the results? Okay, so when we're just looking at some, again, the advantages of evidence-based medicine, it's going to improve the quality of care for patients. Um, it enforces the need for communication skills, because we need to be able to explain the evidence to patients and explain to them why we're doing things. We need to be able to know their preferences so that we can know whether this evidence applies to them or not. Um, this encourages lifelong learning, so we need to continue to, it gives us a way to continue to keep up to date with our patients. Um, it identifies questions that still need to be answered. Like if we have a question, or if doctors in general have a question about something, and there's no evidence in the literature about it, then that shows us, wow, we need to do some studies on that question. It also provides standardization of care, so it provides a certain quality or standard that would be expected of all doctors or hospitals, which is a good thing. Um, it also, like, as we learn how to examine evidence, it improves our critical thinking skills. And because we're not just being given the information, we're having to research the information, decide, is this research good or not good, and does it apply to our patient or not? It helps us keep up to date. It reduces it makes our thinking more rational and more critical, because it's reducing our own kind of just intuition. And as we talked about, if we can reduce some of our own intuition or quick thinking, that can reduce the amount of biases or the number of clinical errors that we are making. And it doesn't completely eliminate our intuition and judgment, because a lot of times we're trying to figure out, in this specific case with this patient, does this apply? And so there's still an important part of clinical experience and clinical judgment, but hopefully this clinical judgment and our decision making can be informed by the best evidence that we have. And also this is important when we're thinking about the ethical or legal aspects of patient management. If we're not staying up to date, we are definitely not providing the best care to our patients. This could lead to a patient suing us and us losing our license, or and also like it's just the ethical thing to do is to provide the best care for our patients. When we're taking our oath of becoming a doctor, we say we're going to try to provide to help our patients and try not to harm our patients. Um, and like I always come back to, God has put us in a special position as doctors. And patients are coming in, they are scared, and they don't know what the right thing to do is. And it is our responsibility to provide them with the best care possible, because just as if they were our own family member, or what we would want if we were if we were sick. This is an interesting topic of just some disadvantages. It doesn't mean we shouldn't use evidence-based medicine, but a lot of times there's not very good high-quality evidence in developing countries. Most studies are done in the first world countries, and so it raises the question, does this evidence really apply to developing countries? It's also costly and it's time consuming. It's costly to put on these studies. I mean, millions of dollars are spent every year on these different studies deciding what treatment is the best. And it's also very time consuming doing the research, and it's time consuming as a doctor sometimes to stay up to date and to continue to read and continue to find the best evidence. And sometimes like we might find results and we just say, man, that is not feasible to apply. Like, should we always get a vitamin B12 level before we treat a patient for vitamin B12 deficiency? Like, is that feasible or is it not feasible if the patient doesn't have money to pay for the vitamin B12 test? It's a hard question. So these are all different websites um, uh, that can be used to research evidence, to look up evidence. These first three are the ones that I really. There's also PubMed that we talked about. Um, these are three other websites that I use most often. Um, this one that's up to date actually requires a subscription. Some of these require subscriptions, some of them do not. For at least some of these, you would get a free subscription while you're a part of the university. Other ones you do need to um, have have a subscription for. But at least for I, I, these first, the Cochrane one, and then American Association of Family Medicine. Cochrane is more, it really just looks up a lot of systematic reviews. Up to Date is a great one, although it requires a subscription. And Dynamed is similar to Up to Date, where you can type in any topic, and I'll show you this, but you can type in any topic like treatment of gout or treatment of diabetes, and it will give you a summary of the evidence as well as give you a summary of the evidence and say, okay, this is exactly what you should do based on this evidence. American Association of Family Medicine, they have a lot of different algorithms. Like if you want a specific, like a big topic, like COPD or anemia, like what are the different differential diagnosis of anemia, and what tests should we order, things like that, just like bigger topics. Um, let's go through a couple examples. So you are an inexperienced junior hospital doctor a 55-year-old man with asthma and heart failure attends your outpatient clinic, and despite taking an ACE inhibitor, his heart failure is still inadequately controlled, like it's not well controlled. You discuss the case with your senior doctor, who advises you to add an angiotensin II receptor blocker, an ARB, to his treatment. So you could just do that, or you can research, is this a good thing to do? And so here are the steps for practicing evidence-based medicine that we talked about. And so first we need to come up with a question, and then we need to find the best evidence. Then we need to examine that evidence and apply it or integrate it with our clinical experience or our clinical expertise. So first thing is the question. So here's my question. In a 55-year-old male with heart failure, would adding an ARB help reduce morbidity, meaning morbidity could be a heart attack or stroke or any other illnesses from the heart failure. In a 55-year-old man with heart failure, would adding an ARB help reduce morbidity compared to just continuing him on an ACE inhibitor alone? So if we go to PubMed, pubmed.gov. Here is the home page. Like I said, it looks a little bit different now. So we have this patient right here with heart failure, and ARB and ACE. Maybe we can come up with something along those lines, those three searches. So if we want to, so here are some of the different things that we can do. Here they have different filters. So we don't have to click on this. I like to click on this sometimes if I really want to read the article. Free full text. If we click off that, we'll get a lot more articles. Right now we have 438 articles. But if you free full text, that means you can actually read the entire article without paying. Otherwise, you would just be able to read the abstract. You can also here refine it based on what type of study was done. You can do it based on all of these different things: the language, the sex of the subjects, what type of journal, all these different things. So you can really limit it there, how old the studies are done. So let's see. We can click on this article right here. And so here's just giving us other similar articles to this one. So we can kind of just like review any of these that seem like might give us information about our patient. So sometimes we'll just kind of like read these different articles. Okay, this one's more talking about effects of this one medication giving hyperkalemia. This one's a different study that was done, a cohort study on different ways of treating heart failure. This one kind of looks pretty good. It's clinical trials of ACE inhibitors and ARBs for treating patients with hypertension, heart failure, and nephropathy. So I might look at this one. Um, you might just kind of look at some different things. Um, this one is talking about okay, angiotensin, so ARBs in heart failure. It's taught this even like this study is comparing giving ARBs versus giving ACE inhibitors, and even in the title, it's showing you that an ACE inhibitor is likely going to be better than an ARB, but it's not specifically telling you whether adding an ARB to an ACE would be the best thing to do. Okay, now I'm gonna change my search criteria slightly. I'm gonna put heart failure and ACE plus ARB. See what we can get here. So this is update of treatment of heart failure. So it's in general, just a general treatment of heart failure in general. That seems pretty broad. Cardiovascular and renal outcomes of renal angiotensin system blockade. And so sometimes you can just even see in here when compared with ACE inhibitor, we're looking, okay, that might be a good one. This one here is efficacy and tolerability of adding an ARB, or an angiotensin receptor blocker, in patients with heart failure already receiving an ACE inhibitor. So that's like exactly really what we want. This one here is ARBs for heart failure. Okay, that's fine, but we really want something that specifically, should we add it? So this is a great article for that. And this actually is a really famous study that was done. So then we can look at the conclusions. An ARB may provide added benefit at an acceptable risk in heart failure patients already taking spironolactone, as well as an ACE inhibitor and beta blocker. So we can, if we look at this study, and we can't look at the whole study right now, and this does take a lot of practice, but right now I just want you guys to start getting used to the idea of just how to find a study that might be applicable to your setting, and then just start thinking about these questions. So is the focus of the research clearly stated? So really, like, this is like the question right here. How how um, um, how good is and how beneficial is adding an ARB to patients with heart failure already receiving an ACE inhibitor? Um, and so, yeah, I think this focus it's really clearly stated exactly what they're wanting. Is it beneficial? And they even talk about in here, like, what the outcomes were. The outcome was cardiovascular death or heart failure hospitalization. So really they were looking at hospitalizations. Did this decrease the hospitalizations when people were on both of the medications? Was the sample size justified? Was it too small? You can see here it was 2,500 patients. That's a pretty good size study. Great studies are probably more like 10,000 patients, but this is still a pretty good one. Did an unwanted event occur during the study? We'd have to really read through the whole thing for that one, but no, it didn't. Is the data described well? We'd really have to read through this whole article, but right here it's describing to us a lot of different things. But really you'd have to read through the whole article to really say, like, is this describing like what the outcome very well or not? And then we could say, are the results of the study valid? What are the results? What does it mean? So here the results are that, yes, adding an ARB to a patient already taking an ACE inhibitor that has heart failure that's uncontrolled could be beneficial, and the type of benefit they're talking about is that it decreases heart failure hospitalization. If we look at different, and then does this compare with previous reports? They didn't really have any studies before this. If we compare this study actually with later reports, it was actually shown that it doesn't make a difference. So this was done in 2008. More recent studies have shown that it actually doesn't provide a benefit. So like, but if we look at certain parts of this study, um, it found that, okay, it significantly reduced heart failure hospitalizations compared with ACE inhibitors alone. Okay, so that's one thing that we found in this study. Another part of this study says that it significantly reduced the combined outcome of morbidity and mortality. So in general, so it decreased heart failure hospitalizations. It decreased a combined, um, uh, if you look at the amount of people with morbidity or mortality problems from heart failure, it decreased that, but but it didn't find any significant difference when you just look at mortality. Like if you just looked at, does adding an ARB decrease mortality, or does it increase life expectancy? It did not have an effect. But if we look at the entire group of patients, that either their mortality rate and their morbidity rate, it did decrease that. Uh, and so but then later studies showed it didn't decrease it. Like later studies that were done better with more patients showed that it really didn't decrease morbidity either. So in general, we don't do this because of, so at this time, people were really thinking this was a good idea. But later studies showed that, you know what, I, it actually didn't really affect morbidity, and so we don't normally add an ARB to an ACE in a patient with heart failure. We choose one or the other, and we normally like to choose an ACE inhibitor. So I hope that's not too confusing. The main, I don't think you, I'm not looking for you guys to be experts yet. But as you get more practice playing with these different websites, hopefully you can get better at looking up information. But the first step, really, go to pubmed.gov, and if like come up with a good question, like does giving a patient metformin for the treatment of diabetes, um, uh, does it decrease their mortality, or does it increase life expectancy? And just see what you get. Um, so, and you might need to like open some different studies. Um, so, um, so I might like just open some of these and read just these first abstracts and say, okay, does this apply to the question that I have? Um, and then if we look at the Cochrane database, for this same type of thing, we can just come to here, Cochrane.org, and then maybe we look for the same type of thing, heart failure um, and ARB plus ACE. We type in the same thing. What do we get? So there's a lot of different articles that are going to come. Some of them are going to come with the same thing. Other ones are going to be slightly different. Um, uh, so are angiotensin receptor blockers an effective treatment for heart failure? So if you're just, there's so much different information, but you can kind of just even scan the titles and say, okay, this one is talking about calcium channel blockers. I want to know more about ARBs. What about, this one's a good one, ACE inhibitors and angiotensin receptor blockers for preserving kidney function in a dialysis patient. Okay, this isn't talking about heart failure. This is talking about dialysis patients, So really, like, this one's probably the best one that they have here. Um, and then they have like this summary, and they're talking about different trials that they've looked at and everything. Um, and then here's even like a little conclusion about it. Um, so these are just, it's a more condensed version, whereas PubMed is going to take you to the actual source, all the reviews of the research. This is going to be a little more of a review of some of the evidence. Um, and if I show you up to date, um, so I find it so beneficial that I have uh, uh, an account that I pay for monthly. And it brings you to this page, and you can a lot of times I'll put in like treatment of heart failure, and then it'll take you to something. Okay, overview over the management of heart failure. If it takes me to here, I really like it. Just like all the different topics are here. So if I want to look at, okay, if I'm just looking at pharmacologic therapy, what's the first therapy I can give? I can click on that and go down here and say, this is normally what we give. If I even want a more summarized version, I can just read the summary of recommendations. And so I can look at who do I need to refer them to, what would I normally uh, give them, is the first line agent. Um, there's even different tables um, uh, that I can use. Um, so I really, really like it because it really brings all the evidence in one area. And then if I want to go look up a specific article, I'll go to PubMed. If I want to know specifically what should I do for a patient and I don't have a lot of time, I really like UpToDate. It also gives me my CME at the same time. The more I look things up, it gives me my continuing medical education uh, hours, and so that I can keep my license up to date. Um, and if I need a more of a summary of something, I might use the Cochrane website. I want to show you the AAFP website as well. Um, this is a free website that you can use. Um, and let's look up like heart failure treatment. There. So it's going to have all these different articles on heart failure treatment. I can take it down by the last 3 months. Um, uh, so here, just heart failure with preserved ejection fraction diagnosis and management. And so um, it's going to show me this article. This is like the summary of the article here. Um, these are the key recommendations. This chart is always really like the most important part is this first part. And then the recommendations that they make. Those are probably the main 2 parts, but then it can go and tell you more, and you can read the whole article why. If I'm looking up a general topic like diabetes treatment or something, I also like to come here. It has a lot of good algorithms sometimes. Um, uh, and so, yeah, I mean, I think you just have to find what's good for you. But personally, I use UpToDate and AAFP the most, sometimes Cochrane for looking up a review about a topic, and definitely, of course, PubMed is the the main one when you're really trying to look up a specific article that you want to analyze. So uh, just last thing here, um, uh, if we have a practice case, um, and this is what I want you to do for homework, is if there's a 4-year-old boy diagnosed with bacterial meningitis is admitted to your ward. We find out he has Haemophilus influenza, and after taking blood samples, you decide to treat the patient with antibiotics. And you know that in some cases, bacterial meningitis can lead to hearing loss. But you think you've read somewhere that maybe treating with dexamethasone can reduce the risk of hearing. So I want you to go through the 5 steps for practicing evidence-based medicine. Find an article that would apply to this case. First of all, I want you to come up with a question. I want you to write down the question. What is your question? And then I want you to find an article using PubMed that would help you answer that question. And then I want you to appraise the evidence, mainly by using some of these questions, and just do your best. And then after that, say, okay, what do you think you should do with this patient? So go through the 5 steps. What's your clinical question? Use that. Make sure you have the PICO format where you're talking about what type of patient, the intervention, comparing it to something, and the outcome that you're wanting. And then after you find one study that talks about the problem, meaning after you find a study that talks about using dexamethasone in a patient with influenza, answer these questions, and then do that again for this case here. For a healthy 50-year-old male, meaning a patient that is a non-smoker, that doesn't have hypertension, no diabetes, just a health, he's not taking any other medicine, he comes to your office and asks whether he should be taking a daily aspirin to prevent a heart attack or a stroke in the future. I want you to come up with a question, go through those 5 steps, go through a question that you can ask that would help you know what to do in this case, and come up with that PICO format. And then after you find a study that talks about the problem, meaning something along the lines of aspirin for the primary prevention of a heart attack or stroke, answer the questions on this slide the best that you can, and then tell me what you would do in this case. So for these 2 cases, that's your homework. I want you to go through it, use PubMed to find an article to answer these questions. And let me know if you have any questions or anything. I know this is a little bit confusing, but I promise you, as you start using these websites, you will get better at it. This is the time to start. You can ask me any questions you have. We can walk through it together on the computer if you're having a hard time. Yep, I'll give you a week to complete the homework assignment as always, and let me know if you have any questions.